During her hospital stay, she bleeds twice and is brought to the endo suite both times. Between the first and the last, she develops a DVT confirmed by ultrasound. She has COPD and CHF. In regards to the DVT, what is the best next step in the management of this patient? A. IVC filter. B. Low molecular weight heparin. C. Unfractionated heparin. Or D. warfarin. And the correct answer is placement of the IVC filter, choice A. The only indication for an IVC filter in the presence of a DVT is to prevent embolization if the patient has a contraindication to anticoagulation, for example, acute hemorrhage, and if the next PE will kill them. This woman has poor substrate already. All IVCs should be retrievable and removed as soon as the contraindication to anticoagulation is corrected. Next question. A 57-year-old man presents to the clinic. He has a 50-pack-year history of smoking and is diagnosed with COPD based on pulmonary function testing. He asks about quality versus quantity of life. Which of the following has shown to have a mortality benefit? A. Fluticasone formoterol. B. Smoking cessation. C. Steroids. Or D. tiotropium. And the correct answer is, of course, smoking cessation. The treatment of the whole patient for COPD is COPDER, which stands for corticosteroids, oxygen, prevention, flu vaccines, pneumonia vaccines, and smoking cessation, dilators such as LABAs, LAMAs, and ICS, and experimental, like valves and transplants that don't really work, and rehab. Most improve the quality of life, reduce readmissions, and the like. The only things that let people live longer is smoking cessation and oxygen use when indicated. Next question. A 68-year-old man presents to clinic for exertional dyspnea. He has a 40-pack-year smoking and a chronic cough. He also has hypertension and diabetes that are controlled with medications. His vitals are normal, except for a saturation of 88% on room air. He is obese. He has no JVD, displaced PMI, or crackles. There is peripheral edema from the toes to the mid-shin and digital clubbing of the digits of the fingers and toes. His lungs do not have wheezes or crackles. Which of the following is most likely to identify the diagnosis? A. Arterial blood gas. B. Chest x-ray. C. Echocardiogram. Or D. Pulmonary function tests. Of course, the answer is going to be D, pulmonary function tests. So this question asks, can you identify the blue bloater of COPD? This person has pulmonary hypertension from COPD. He has a smoking history, he has a chronic cough, and none of the findings of left ventricular dysfunction. But he does have some findings of right ventricular dysfunction. So recognizing this as COPD means that the diagnosis can be made pulmonary function tests. Next question. A 67-year-old woman presents to the clinic with COPD exacerbation. She has a barrel chest, cachexia, and hypertrophied intercostals. She has prolonged expiration. She has a 50-pack-year history of tobacco cigarettes. She currently uses salmeterol and tiotropium. Her vitals are normal, though she does have some expiratory wheezes. On arterial blood gas, her pH is 7.4 and PCO2 is 70. What do you do at this visit? A. Add inhaled corticosteroid. B. Add prednisone. C. Obtain pulmonary function test before and after bronchodilator. Or D. Observe the use of spacer and inhaler. And the correct answer is D. Observe the use of spacer and inhaler. So this woman has not exacerbated her COPD. Even though her PCO2 is elevated, she has a normal pH. So people with COPD can wheeze even without exacerbation. She has all the features of a pink puffer. With that, the first step for someone who might be exacerbating is going to evaluate them for spacer use. This is the right answer when the patient isn't overtly ill, like in a clinic, and there has been inadequate control of the COPD symptoms. So first, we're going to make sure that they're using the spacer properly and do that through the observed use of the spacer in your office. Next question. An 82-year-old man presents to the ED with dyspnea. This man has a history of COPD and is not on home oxygen. He takes his inhalers and states that he is adherent. His vitals are normal except for a 92% oxygen saturation on room air. He has prolonged exhalation, hypertrophied intercostal muscles, and is generally thin appearing. His x-rays revealed a flattened diaphragm with 13 ribs visible and hyperinflated lungs. His blood gas shows a pH of 7.2, a CO2 of 88, and an O2 of 62. What is the next step in his management? A. Apply bilevel positive pressure ventilation, or BiPAP. B. Intravenous azithromycin. C. Intravenous piperacillin tazobactam with vancomycin. Or D. Nebulized ipratropium and albuterol. And the correct answer is D. Nebulized ipratropium and albuterol. So the first step in managing a COPD exacerbation, evidenced by history of COPD, non-adherence in the physical findings, and that CO2 retention giving a pH of 7.2, is combined albuterol ipratropium inhalers. Here's the board's insider tip. When you're approaching a question like this, you'll notice a lot of these things are things you're going to do, right? A lot of the answers are technically things you're going to do in the management of the patient. Combined inhalers and IV steroids and BiPAP and IV azithromycin, they'll all happen at once really in the emergency department. But the question doesn't ask you that. It asks what is the next step in his management? And the next thing is nebulizers. So we get that on board ASAP. Next question. An 82-year-old man presents to the ED with dyspnea. The man has a history of COPD and is on home oxygen. He takes his inhalers and states that he is adherent. His vitals are normal except for a 70% oxygen saturation on room air. After receiving 3 rounds of inhaled albuterol and ipratropium, as well as delivery at 15 liters of oxygen, the repeat ABG shows a rising CO2. The lungs are silent and the patient becomes altered. What is the next best step in the management? A. Initiate bilevel positive pressure ventilation or BiPAP. B. Intravenous methylprednisolone. C. Rapid sequence intubation. Or D. Repeat nebulized albuterol and ipratropium. And the correct answer is rapid sequence intubation. I hope you got this one. The absence of wheezing is generally considered a good thing with obstructive lung diseases. However, this is a patient where there's no normal lung sounds even coming through, silent breathing, which means they're not even ventilating. The patient has a COPD exacerbation that is failing to respond to inhaled therapy. The lung is completely silent. We need to get the patient intubated as quickly as possible with this rising CO2. They're now becoming encephalopathic, altered mental status. Intubate them, protect the airway, get the person ventilated. That's our number one goal. Next question. An 84-year-old woman is admitted to the hospital for COPD exacerbation. She is flu antibody negative. She has a cough, wheezes, and increased sputum production. She is pleasant with normal vital signs. She does have expiratory wheezing and an oxygen saturation of 92% on room air. An x-ray reveals flattened diaphragms, but no consolidation or effusion. She's admitted and IV methylprednisolone and inhaled nebulizers are started. In addition, which of the following is the best next step? A. Cephalexin. B. Doxycycline. C. Moxifloxacin. Or D. Vancomycin and pip/tazo. Correct answer for this is doxycycline. In the setting of a COPD exacerbation, the GOLD criteria dictate who should get antibiotics. Those patients with increased sputum production who also have no evidence of a clinical lung infection, such as consolidation, get antibiotics, assumed to be from a bacterial bronchitis. Often cited, but unfounded, is the anti-inflammatory effects of azithromycin. Not all COPD exacerbations need antibiotics, but those that do get them should get either azithromycin or doxycycline. There are a few others, and they should be rotated each admission.